Hello there, everyone. Good afternoon. Hope you're all doing well today. Welcome to our session. My name is Alice Nelsner, and I'm the CEO at the San Bernardino County Medical Society. We are very excited that you can join us for our fourth in our series of clinical education webinar sessions. And today's session is Medicare annual wellness visits for primary care, best practices and better outcomes. And we are very, very excited to have one of our longtime members and most steadfast leaders with us presenting today, Dr. John Frank Randolph. Dr. Randolph is family and geriatric medicine specialist, as well as a consultant and a former geriatric section chief with Arrowhead Regional Medical Center. Dr. Randolph has also been a very long time member of our District 2 delegation, which we share with Riverside County Medical Association. So we are incredibly thrilled to have someone that has put so much time and energy into the medical society be sharing insights today. We are partnering with Riverside County Medical Association on this series, so we thank our sister organization for joining with us to put this together. And we want to give a huge shout out to IEHP for funding and supporting this series. And as I mentioned, we have 12 of these in total. So there's one each month. And if you can go to our website, sbcms.org, you will find a way to sign up for any of the future sessions that are currently scheduled. Each month is a different topic. At the end of the presentation, we will provide instructions on how to apply for CME, continuing medical education, for those of you who are providers and would like to get 1.25 CME credits. So with that said, I am going to welcome our star of the show today, Dr. Frank Randolph. Dr. Randolph, take it away.
Oh, wow. Okay. Thanks for the nice introduction. It's a pleasure to do this. It's a lot of fun. I can see some familiar faces on the chat on my screen. So I'm going to go ahead. This talk is about an offering from Medicare that's been around for a while, and I'm going to describe the program and the elements of the program, and then how to achieve reimbursement, how to code and document. Well, I just tried to page down, but that didn't work. Okay, here we go. So the background on this is that it really comes from the Affordable Care Act in 2010, and that was a precursor. In 2011, Medicare started paying for an annual wellness visit, which included a health risk assessment with a medical history, development of a preventative screening schedule, and a personalized health planning. And then there's another visit called the Welcome to Medicare Preventive Visit that the wellness visit supplements. And the initial preventive physical exam is a one-time assessment offered in the first 12 months of enrollment to Medicare.
Hey, Dr. Randolph, can I interrupt you real quick? I'm not seeing your slides up. If we want to try to get your slides up here.
Oh, I thought they're on my screen.
Oh, do you guys see them, or is it just me not seeing them? Is anybody else? Can you let me know if you see them?
Hey, Allison, this is Evelyn. I can see them.
You can? Okay, never mind, you guys. It's just me. Okay, sorry, Dr. Randolph. Go ahead.
I'm on my third slide now.
Okay.
The slide says components of IPPE. Can everybody see that?
Now we can see.
Yeah, I see it now. Dr. Salinas, can you see it now?
Ken?
See it now.
See it?
Okay, we've got it. Sorry about that, Dr. Randolph. It looks like we're good. Okay, we're good.
So the initial preventative physical exam is not really a physical exam. It's more like a screening. The person that's doing it has to review the patient's medical and social history, past medical, surgical history, meds, family history, diet, physical activities, social activities and engagement, alcohol, tobacco, and illegal drug use. They've got to review the patient's potential depression risk factors, such as current or past experience with depression, other mood disorders. And you can use a screening tool for this. And I have some examples in my chats of screening tools. The next is to review the patient's functional ability and safety level, to use direct patient observation, appropriate screening or standardized questionnaires, to assess the patient's ability to perform ADLs, fall risk, hearing impairment, and home and community safety, to do height, weight, body mass index measurements, blood pressure, balance, and gait evaluation, a visual acuity screen, and other factors deemed appropriate based on medical and social history. In addition, end-of-life planning. Of course, if the patient doesn't want to talk about end-of-life planning, it's optional, but it's offering the patient verbal or written information about their ability to prepare an advance directive. And then if the practitioner wants to follow their directive, and that includes psychiatric advance directives. Number 6 is to review current opioid prescriptions. If the person has an opioid prescription, to review any potential opioid use disorder risk factors, pain severity, and current treatment plan. 7, to screen for potential substance abuse disorders, to review the patient's potential substance abuse disorders. 8, to educate, counsel, and refer based on the components I went over just now, and provide the patient with appropriate education, counseling, and referral. 9, to educate, counsel, and refer for other preventive services, including a brief written plan like a checklist. One is they also can refer for an EKG, and that's actually additionally reimbursed. And then the other appropriate screenings and covered preventive services. Now, the billing codes for this exam, G0402, that's for the initial physical exam. If you do an EKG2, there's a billing code for that. And there's also a specific code if you're working out of a federally qualified health center. Now, who can provide these exams? A physician, a doctor of medicine or osteopathy, a qualified non-physician practitioner, such as a nurse practitioner, a physician assistant, or a clinical nurse specialist. Now, to keep everybody awake, because I know this is very dry, I have a quiz here. The CPT code for the initial preventive physical exam is A, G0402, B, G040100, C, G0468, or D, unnecessary. And the answer is G0402. And you see these two buffoons trying to manage their box here. Some of you might recognize Gahan Wilson. He is a strange cartoonist. Another question, the initial preventative physical exam is A, a preventative wellness visit and not a routine physical exam. B, does not include review of past medical records. C, cannot be completed by a nurse practitioner. Or D, does not require that a diagnosis code be reported. I'll let you percolate on that. As you can see, my consultant, Mr. Bean, helped me prepare this question. And the answer is it's a preventative wellness visit and not a routine physical. That comes up throughout all of the descriptions of these exams, is that it's not a routine physical. Now, the first annual wellness visit, it's very similar in some ways to the IPPE. It includes a health risk assessment with a medical history. It can be completed by a physician or a non-physician practitioner, a nurse practitioners, But it can also be completed by registered nurses or other medical professionals, like a health educator, a registered dietitian, working under the direct supervision of a physician or a nurse practitioner. The same level of Medicare reimbursement for subsequent annual wellness visits is provided regardless of who completes the visit. Now, historically, these visits have been predominantly completed by physicians or nurse practitioners, despite the fact that they're within the scope of practice of RNs and other medical professionals, which is too bad, as you'll see as we move on. The components are, and I have an example form that you can use for the health risk assessment in this referral here. The component one is to establish the medical and family history. Component two is a list of current providers and suppliers. 3 is measure height, weight, body mass index, and blood pressure. 4, to check for cognitive impairment, you can assess the function by either direct observation or reported observations from family and others. And you can, but you don't have to use a brief cognitive test. And I have some examples of those in my chat box. Review the patient's potential risk, depression risk factors. Review the patient's functional ability, ADLs, fall risk, hearing impairment, and review home and community safety. And then finally, establish an appropriate written schedule and base it on the checklist for the next 5 years from the U.S. Preventive Services Task Force. Now, again, choosing those tests is kind of dependent upon certain caveats. Many aspects of mortality in older adults are modified through behavior change, and people over 65 should be counseled on smoking cessation, diets rich in fats, aerobic exercise, and strength training. Other kinds of preventive care include aspirin therapy, lipid management, and then vaccine administration. The first annual wellness visit also includes establishing the patient's list of risk factors and conditions, and then choosing recommendations for primary, secondary, or tertiary interventions. The number 9, provide personalized health advice and appropriate referrals to health education or preventive counseling services. 10, provide advanced care planning at the patient's discretion. So that's a discussion with the patient about preparing an advance directive, future care decisions they might want or need to make, how they can let others know about their care preferences, who their caregiver is, and other these advanced directive elements, which may involve completing standard forms. Also includes 11, reviewing current opioid prescriptions, 12, screening for very much like the preventive exam, and then social determinants of health risk assessment. And there's an example tool, like the prepare tool, that you can use. And again, the health risk assessments can be prepared ahead of time by staff and sent to patients or administered to patients in the office. Now, the annual wellness visit, very similar reimbursement codes, G0438, G0439, and they're sort of based on similar Medicare codes. And then you can also bill, if you do advanced care planning, you can bill separately for that. And if you spend more than 30 minutes, you can bill additional time. And if you administer a standardized evidence-based social determinants of health assessment tool, you can also bill for that. Now, annual wellness visit coding. annual wellness visit was A, developed by Ron Burgundy in 2011. B, consists of up to 9 separate clinical criteria that must be met in order to be billed. C, does not require a health risk assessment. D, must include a mandatory discussion. Well, what do you think the answer is? I don't think Ron Burgundy developed this. Although sometimes when I look at the detail that you need to provide, I wonder if perhaps he did. Anyway, the correct answer is B. It consists of up to 9 separate clinical criteria that must be met in order to be billed. You can discuss advanced care directives, but it's not mandatory. And you have to do a health risk assessment. So the annual wellness visit was A, developed by the California governor. B, does not require a review of the functional ability. C, may be completed without a health risk assessment. Or D, includes optional discussion of the patient's advanced care directive. I don't know if you recognize this background here, but this is Governor Newsom announcing a plan to clean up the Yuba River. This is a picture of the Yuba River near the home I grew up in Marysville. Anyway, the answer is that the annual wellness visit includes an optional discussion of the patient's advanced care directive. Now, the documentation that when you're doing this, it goes in the patient's chart, and your billers may have to, they don't have to, but they may be asked to provide evidence that this occurred by virtue of those records. And the record has to show who did it, who performed the exam, and it has to include patient consent, the date of the visit, the mode like telehealth or in person, and all the services performed, including any standardized tools and assessments and by whom they were completed. This is an example written screening schedule that I put together on one slide. It's in a couple of references that I have in the chat box, but you can see this is, if you complete this in its entirety satisfies documentation for the annual wellness visit. Now, the problem with the annual wellness visit is that, and again, this is from a survey done right after it came out, that 68% of patients had not heard of it, and only 17% had received it. A CMS survey showed that 8.8% of Medicare patients had received it. So not a lot of utilization. And then when studies were done of doctors doing this annual wellness visit, a lot of doctors were confused about competing expectations. Often they ended up doing it all during the visit. In other words, instead of just doing the wellness part, they would address new patient concerns, review chronic problems, and complete the wellness questionnaire, and then finally conduct a full physical, which was not required. So they felt overwhelmed by the number of items to be covered at a visit, and that they needed to accommodate the patient's expectations for the free Medicare visit. Some question the science behind the inclusion of an EKG with the visit. When you look at the model for the wellness exam, they want you to use the United States Preventive Services Task Force recommendations. But those recommendations are based on an evidence-based model for prevention of specific disease. So the approach is somewhat flawed because many geriatric disorders have multifactorial risk factors, interventions, and expected outcomes. Older adults are often not represented in clinical trials, and important outcomes may not be measured and reported in ways that are conducive to evidence synthesis and interpretation. Studies, in 2013, JAMA produced a study that health check offers were not associated with lower rates of all-cause mortality, mortality from cardiovascular disease, or mortality from cancer. What they are associated with is more diagnoses and more drug treatment. Morbidity was infrequently reported, as were most harms, such as the use of diagnostic procedures. So a little bit of criticism there, but it's not arbitrary. This is based on a study. Well, I haven't heard anything, or I'm not able to read the chat to see if there've been questions so far, but I'm open to answering any questions that there may be regarding my presentation up to now.
That was fantastic, Dr. Randolph. That was a really good overview, and I'll go ahead and facilitate the questions. So really quickly, before we jump into questions, I don't want to turn this, our intent is not to turn this into a discussion of the politics of Medicare, but since many of you have tuned in to receive updates, I do want to let you know that with regard to the bill that we're all holding our breath in suspense about at the congressional level within the House Energy and Commerce Committee, we have found out that the final bill proposal includes a Medicare physician payment provision that would update Medicare payments in 2026 by 75% of the Medicare Economic Index. And as you know, AMA has been concentrating much of their energy in fighting for this, as it has CME. And so this would be a 2.6 to 2.8% increase. Okay, we know that it was cut 2.8% going into this year. In 2027 to 2034, that provides a 10% of the full Medicare Economic Index MEI update. But the problem with this is, not to be negative, Nelly, but the problem with this is that's equal to or less than the current law annual update in 2027 to 2034 of 0.25% for the fee schedule and 0.50% for value-based care. The good side of this, the positive side of this, is that the update is permanent and does not create yet another temporary cut in 2027, and it establishes the MEI permanently in the law, finally, so organized medicine can advocate for rate increases above the MEI base rate rather than the current conversion factors. It doesn't stop the 2025 payment cut, which unfortunately reduces the conversion factor baseline for 2026 and beyond below 2024 payment levels, even with that 75% of the MEI increase. Anyway, AMA has communicated a support position because of the positive aspects of this bill, and CME is evaluating this. So I wanted you to know what was going on with that as a side note and kind of an adjunct to Dr. Randolph's presentation. So, and Kelly, this bill is the biggie that House Energy and Commerce Committee is putting together for the, the one that where we're hearing so much hoopla about with what's going to happen with regard to Medi-Cal cuts and all of these other cuts that have been proposed by the federal government. So we're seeing they're going to have to reconcile this with the Senate and come out with a final version. And we are hoping that happens before early July. So, okay, I don't want to take away from Dr. Randolph's point though. So who has some questions here? I don't see any in the chat besides mine.
What's the best resource, doctor, that you would say for providers and business owners to look at for these different updates?
Well, I have some in the chat box, some resources. I mean, if you Google annual wellness visit, you'll see there's all kinds of stuff, especially if you use Google Scholar, but there's a lot of references. Medicare's developed on the Medicare learning website, Medicare's developed several decent references.
Will you be able to share your slides, Dr. Randolph? Are you okay with us sending out your slide deck?
Yeah, absolutely.
Okay, because you had some good examples of some other forms and templates and things in there too.
Yeah, you can see on the references on this reference slide that there are a number of references that I used. I think that, and also if you go to the CDC website, it covers a lot of the preventive recommendations of for vaccines and health screenings in older adults.
Okay, that's
To help you
great.
make it.
That's great. Who else has a question today for Dr. Randolph? Feel free to just speak up or raise your hand, please. Okay, well, I have one, Dr. Randolph. What's your experience in terms of the comfort level of seniors and the Medicare population in receiving vaccinations? And does that differ between flu and COVID, and how, what do you find with that?
Well, I honestly, I don't know. My own experience is that I never had any significant problem with the seniors accepting the vaccines.
Interesting. Okay.
I mean, I don't think I've ever met a vaccine, well, maybe one, but a vaccine denier among the senior population. Maybe that's going to change. I don't know.
They're not as likely to
Well,
be opposed to it or question it as
a lot of
much.
seniors are very, I don't know, old school ideas that we get a lot of respect. Doctors get a lot of respect from seniors, and trust.
Yeah.
Of course,
Yeah.
the ones who don't trust us probably don't show up in our office. So
Yeah.
my perspective is probably biased.
Yeah, that's right. That's a good point too. Maybe it's already a receptive audience. Yeah. Okay, well, come on, guys. We don't want to let you go yet. No more questions, huh? Well, all right, then I guess if we don't have any more comments or questions, we're going to give you back some of your day today. I think you've done such a good job, Dr. Randolph, of covering everyone's curiosity about how to really approach this, that you've answered it all for them. So we want to thank you so very, very much for putting this together today and joining us, and really help kind of clearing this up as procedurally for our other providers. And I'm seeing lots of thank yous coming in on the chat from Dr. Salinas and Dr. Malum, and Dr. Frausto, Dr. Na, and Dr. Snyder. All right. Well, will you do this again for us maybe in the future, Dr. Randolph? Maybe next year?
Sure.
Okay. Okay, well, we sure appreciate it. And everyone, please be sure to tune in next month, June 19th. And our presenter will be Dr. Eric Hansen on diabetes, heart and kidney disease, asthma, and other chronic conditions. And the topic will be controlling those before they get out of control. So please mark your calendars for June 19th, and we'll get that sent out right away. You can register on our website or by scanning the QR code that is on your screen right now. Our website is sbcms.org/events, and you can find it listed there and just click to register. So, all right, we thank you all very much once again for joining us. So Dr. Randolph, thank you. Have a great rest of your week.
Thank you.
See y'all soon. Bye-bye.
Bye-bye.